Barbara, University of Science and Technology. I'm the HID currently of my department. So I'm here to present substance use disorder among people with primary mental illnesses, but it's work of my students, it's not my work, but I was providing the students, so I thought I could share the work and we get to know what happens among our patients. So we were inspired by literature, which says that the number of people using addictive substances is increasing globally, but more so among people with mental illness. And one systematic review involving 123 studies showed that about 41% of the people who are with mental illness actually had substance use as well. So substance use is linked to especially primary mental illnesses. Think of schizophrenia, think of mood disorders, and more so personality disorders. And the reason these people may be using these substances is likely because maybe impaired judgment because of the illness. Maybe they want to mitigate the effects of the illness and the medication that they are, using. Yeah, so that puts them at the risk of abusing drugs. But also we get to know that people with mental illness, if they take substance, this complicates their behavior, impairs access to treatment, and also impairs their compliance to medications, of which we get to see severity of symptoms, getting worse, other medical complications, impaired functionality, and of course the risk of mortality gets high. And then we see other factors like being male, people who have history of adverse childhood experiences, high level of education, surprisingly, but also less involvement in religious activities increases the risk of substance use in this population, but also get to see that social support and also quality of social relationships increases or reduces the risk of getting involved in these substances. That is according to literature. Okay. Yeah, so we get to see that spirituality and maybe other religious activities tend to help these people, and I mean people with mental illness, to not use these substances because religious activities tend to provide social support, promote hope, but also fosters the positive view of the world. So if these people have these symptoms, have confusion, and they get this kind of support, then they are not able to use substances. So we get to realize that as much as we get to know this from literature, we didn't have much information about this topic in our setting, so we thought let me put this one down. I thought we would do this in our setting and get to communicate to the world what happens in southwestern Uganda specifically. And so we came up with this study. I don't know how far we are. Okay. Yeah, methods. So this was basically a cross-sectional study done in the hospital, and we're targeting patients with mental illness, primarily schizophrenia, bipolar, and major depression who were attending outpatient clinic. And we're targeting adults, so we're looking at those who are 18 years and older, confirmed diagnosis of either bipolar, schizophrenia, or depression. And they didn't have to have symptoms of mental illness actively because we needed them to provide consent and be able to give her the information that we needed. Yeah. So our main variables were mainly, when I mentioned substance use, we're only considering alcohol and cannabis. We didn't go deeper into other substances. So we used the AUDIT, or the audit, as we normally call it, to screen for alcohol use, but also the cannabis use disorder identification test to screen for cannabis use. And then we also collected information on social support, religiosity, and then adherence to psychotropic medications, and also on clinical factors like history of alcohol use, cannabis use, prior history of use of these substances, type of mental illness diagnosis that the person has, as well as previous admissions and age of onset of these conditions. Data analysis, I hope all of us are there. So we used this data to get to analyze our data. We summarized continuous variables as means and standard deviations, categorical variables as proportions and percentages. Then we ran logistic regression, mainly to understand the factors associated with substance use in our population of study. And we ran multivariate regression analysis where we made sure we included factors that had a p-value of 3 or less than 0.3, or maybe according to literature, we find that some factors that we included actually mentioned in literature as factors associated with substance use in the population, considered significant at 95%, confidence interval and p-value of 0.05% or below that are significant. And just not to leave you behind. So we made sure the study was approved by the Research Ethics Committee of Marine University of Science and Technology, but also participants provided informed consent for them to be able to participate in the study. As I said earlier, they had to have symptoms reduced, rather had no symptoms, so that they are able to understand what the study was about. Yeah, so we recruited about 385 participants that we included in our analysis. Mean age was 38.9, and 51.17% were women, and 47% had bipolar disorder. So overall, 13% had substance use disorder, 11.69% had alcohol use, while 5.4% had cannabis use disorder. Okay, busy table, but I just wanted to point out that, as I said earlier, mean age was 39, and taking you to lower to the primary diagnosis, 61 had depression. So majority actually had bipolar disorder, and that's not common in our setting. We tend to see more of our patients with bipolar disorder. Yeah, then table, this is really continuous of the other table. I'll just jump that one. So on the factors associated, we saw that being male and having prior history of substance use, either cannabis or alcohol, were associated significantly with substance use. Then also see that adherence, either moderate or high, were associated, or rather improved or lowered the risk of using substances. So discussion. Okay, sorry, I left you behind on the tables. Yeah, so we found overall the prevalence was 13.25. We found that being male and prior history of substance use increase the odds of using substances. However, adhering to your treatment lowered the chances of using these substances. And this is the 13% that we found compares to a study that was run previously in Uganda, but this was Central Uganda, while our study was in Western Uganda. And quite lower compared to the study done in Tanzania, but we also found out that the study in Tanzania found 68%, but this was because for them they considered all substances, while for us we focused more, rather only on cannabis and alcohol. So yeah, so we couldn't compare with somebody who maybe included smoking, tobacco, or maybe used cocaine. For us, we were focusing on those two substances. So that's why we tend to see that our prevalence was quite lower compared to the study done in Tanzania. So the association between male gender and substance use has also been found in other studies in sub-Saharan Africa. You can mention Nigeria, South Africa. And then we tend to see that men are more into high-risk behaviors, of which substance use is another one of those. So they tend to use alcohol mainly, but also our culture settings, culture influences or culture beliefs in our setting tend to promote men to using these substances rather than supporting women to be involved in those behavior. Yeah, so that's why probably we found that more of our people were using more of alcohol. The association between adherence to medications and low use of substance use, is similar to what has been mentioned previously, but we also get to know that the relationship could be bidirectional. If you're using substances, chances are high you're going not to adhere, but also if you adhere, chances are high you're not going to be taking these substances. So that is something to note. Yeah, so we did not find a significant association between religiosity and substance use disorder in our setting. And although literature says there's a relationship, religiosity or religious involvement lowers chances of using these substances among people with mental illness. That churchgoers, who are at risk of substance use, primarily they get to form social networks that are supportive and help them to cope with these substances, so they tend not to use these substances. Our study is limited by a number of challenges. Number one, this was conducted in one setting, and so you cannot say, hey, this is generalized all over Uganda. Our people in Uganda is multicultural, so Western Uganda may be having its own beliefs and other challenges that are there that may not be the same as Eastern Uganda. But also, this was cross-section in nature, and so you cannot determine the cause-effect relationship because of its nature being cross-sectional. Then the tools used, some of them have not been used in Uganda. For example, religiosity has not been used in Uganda. So we just use the tool and maybe it could affect our study findings. And the tools were screening in nature, they were not diagnostic. So that could have maybe overestimated. Just not leave you behind. I'm on the study limitations, sorry about that. Yeah, so the tools could have overscreened. And we tend to have a high number of substance use when actually maybe it was lower, but those are study limitations. So in conclusion, substance use disorder is really common among patients with mental illness, primarily the major ones, schizophrenia, bipolar, and maybe major depression. And adherence to medication is really protective against these challenges. So when we think about intervention that can prevent substance use, because we saw in literature that substance use worsens access to care, worsens outcomes basically. So we need to prevent this happening. And so when we think about interventions that can prevent substance use in our patients, we need to think about how can we promote treatment adherence among our patients. And then we can improve outcomes and prevent substance use. Acknowledgements, our study participants, our research assistants, but also I acknowledge my funding from Fogarty, the CARE grant that I'm currently undertaking. Thank you so much.